Today we talk about endometriosis, deep pelvic endometriosis, and the role of magnetic resonance in its diagnosis. As you know, endometriosis is a chronic multifocal gynecological disease which is characterized by the presence of functional endometrial tissue outside of the uterine cavity. These ectopic endometriotic lesions can respond to hormonal stimulus, especially by estrogen, with cyclic hemorrhaging. We know it's an extremely common disease, although often underdiagnosed. Its prevalence goes up to the 10 to 70% of women with chronic pelvic pain. We know there are many risk factors associated with endometriosis, especially an earlier age at menarche and a shorter cycle length. This must mean that the exposure of the women to the estrogenic stimulus is longer. There are many other risk factors associated with endometriosis, such as familiarity, which is increased by 7-fold for women with the first-degree relative with endometriosis, and also the increase of pro-inflammatory factors, such as the interleukin-6 or the TNF-alpha. There are many pathogenetic theories associated with the pathogenesis of endometriosis. The first one was surely the Sampson's retrograde menstruation theory, which postulated that the reflux of viable endometrial lining cells through the fallopian tube into the pelvic cavity can cause the differentiation in endometriotic lesions. But since retrograde menstruation is a phenomenon commonly associated with menarche and menstruations, of course, it's not necessarily associated with the menses. I'm sorry. It's not necessarily associated with the development of endometriosis. This must mean that there must be many other factors of immunological, genetic, or inflammatory nature that can contribute to the pathogenesis of the disease. Another theory is the metastatic theory, which can explain and justify why there are many endometriotic lesions outside of the pelvic cavity, such as the thorax or the sciatic nerve. The metastatic theory postulates that the endometrial lining cells can travel through the bloodstream or the lymphatic channel to locate themselves in ectopic locations. Another theory is the metablastic theory, which postulates that the differentiation of the coelomic epithelium receiving from the Mullerian tissue can persist and develop into endometriotic lesions under the stimulus of the estrogens. And lastly, we have the induction theory, which combines all the previous theories I mentioned, postulating that the shed endometrium itself is capable of releasing substances that are capable of differentiating the coelomic epithelium into endometriotic lesions. Now let's review briefly the female pelvis anatomy, which is very important to characterize and locate all the endometriotic lesions. We know that according to functional and clinical criteria, the female pelvis is divided into 3 compartments: an anterior, middle, and posterior compartment. The anterior compartment comprises the urinary bladder, the urethra, and all the anatomical spaces surrounding them. We have anteriorly of the bladder, we have the pre-vesical space, which is an adipose partition, extraperitoneal adipose partition, which separates anteriorly the bladder from the posterior aspect of the pubic symphysis. Posteriorly, the bladder and the urethra are separated from the vagina with the fibroadipose partition called vesicovaginal septum, which is also extraperitoneal. Above, we have the 2 reflections of the peritoneum above the bladder dome, which are anteriorly the prevesical recess and posteriorly the anterior cul-de-sac, or vesicouterine recess. The middle compartment comprises the uterus, the adnexa, and the vagina. We know that the uterus is kept in place by a complex mechanism of ligaments and peritoneal folds. There are many regions involved in endometriotic lesions, such as the vaginal fornices, which are the deepest portion of the vagina, extending in the deepest portion of the vaginal canal, surrounding the extension of the cervix. In particular, the posterior vaginal fornix is associated mostly with endometriotic lesions. Let's review briefly the uterus stability and its mechanisms. Firstly, we talk about the broad ligaments, which aren't the ligaments themselves, but are peritoneal folds, which extend from the lateral aspects of the uterus to the lateral walls and pelvic floor. We know it comprises 3 portions: the mesosalpinx, which contains the uterine tubes, the mesobilium, which contains the ovary and the ovarian vessels and nerves, and the mesometrium, which is the broadest part that contains the uterine arteries. We know that the broad ligaments continues itself upward with the round ligaments and the proximal part of the round ligaments and the suspensory ligaments of the ovary. Now we talk about the round ligaments, which is a residue of the gubernaculum ovari, which was a structure that during embryonic life carried the ovaries from the posterior abdominal wall to its current location. We know that the round ligaments extend themselves from the uterine horse through the inguinal canal, terminating in the connective tissue of the perineum near the labia majora. And lastly, we have the means of stability of the cervix, which are arranged mimicking, as you can see, the spokes of a wheel. Anteriorly, we have the pubocervical ligaments, which extend from the anterolateral aspects of the cervix, terminating in the posterior aspect of the pubic symphysis.
Sorry, was it a radiographics drawing this?
Yes.
Yes.
Yes,
That's the reason why I stress you with the radiographics, because it's a very educational journal.
Yes.
Normally treat the subject from the beginning, from embryology, anatomy, with very good drawing that must be kept in your mind.
Yes, reviewing the anatomy was very important to talk about the endometriosis.
Yeah.
And the lateral ligaments are the cardinal ligaments or macron ligaments, which extend from the lateral aspect of the cervix to the lateral walls of the bony pelvis. And lastly, posteriorly, we have the uterosacral ligaments, which extend dorsocranially from the posterolateral aspects of the cervix, terminating in the anterior aspect of the sacrum. The uterosacral ligaments are very important because they are very common locations of endometriotic implants. Lastly, we have the posterior compartment, which comprises the rectum and all the anatomical spaces. The rectum is separated anteriorly from the vagina from a fibroadipose partition called the rectovaginal septum, which is also extraperitoneal. Above the rectovaginal septum, we have the retrocervical region, which is a virtual extraperitoneal space, common location for endometriotic implants, and above we have a posterior reflection of the peritoneum, which is the Douglas pouch. We see with the white asterisk the fibroadipose partition, which is the rectovaginal septum, and with the black arrow the Douglas pouch. This is a sagittal T2-weighted imaging of magnetic resonance, and we see that both the vagina and the rectum are
Why
filled.
are you so sure that it's a T2?
Because we see fluids which are hypointense.
For your...
Yes, of course. In the T2 sequence are fluid-sensitive sequences, which means that all structures containing static fluids, such as the urinary bladder or the gallbladder, of course, appear hyperintense. In this image in particular, we also see that the vagina and rectum inside are filled with a hyperintense fluid, which is a sonographic gel, which is used during this examination. We have many types of lesions in endometriosis. The most common ones are the SUPs, which are the superficial peritoneal implants, the DIE, which are the deep infiltrating endometriotic lesions, and the OMA, which are the endometriomas or ovarian endometrial cysts. Today we focus our attention on the DIE, which are the deep infiltrating endometriosis. For deep infiltrating endometriosis, we define one or more subperitoneal lesions which extend further than 5 millimeters on the surface of pelvic organs or tissues. It involves up to 20% of patients with endometriosis, especially involves the rectovaginal septum and the uterosacral ligaments up to 69% of cases. Now let's talk briefly about the symptoms of endometriosis. Often it's asymptomatic, especially if there aren't any deep infiltrating endometriotic lesions, and this causes a remarkable diagnostic delay of up to 7 to 10 years, and it's an important cause of infertility, as we mentioned earlier. We know that gynecological symptoms are dysmenorrhea, dyspareunia, chronic pelvic pain, and metrorrhagia, but we also have many other symptoms associated with the locations and deep infiltrating endometriosis. For the bladder, for example, we can have dysuria, hematuria, urinary storage symptoms. For the rectosigmoid, we can have cyclic pain or rectal bleeding. For the
very specific symptomatology in general, because there is a wide range of differential diagnosis for this.
Of course, an accurate gynecological and instrumental examination must be made to ascertain the diagnosis. For atypical locations, such as the thorax, we can have chest pain, especially on the right side, that we'll explain why later on, and cervicobrachial pain in case of apical implants, catamenial pneumothorax, and hemoptysis. For the sciatic nerve and sacral nerve root locations, we can have a pain in the spine and gluteus which extends and radiates to the lower limb, positive lasage sign, and sensitivity alterations. Of course, we mentioned earlier that it's an important cause of infertility for many mechanisms which are also supposed and not yet confirmed. The diagnosis is made initially with an accurate and systematic gynecological examination which can reveal painfulness during pelvic palpation, or for example, a painful anorectal exploration in case of DIE in the rectus sigmoid, or palpable nodules or thickening of ligaments or adnexa. The laparoscopy still remains the gold standard for the diagnosis because even if the sonography or even the magnetic resonance are negative, it can allow us to do a biopsy with the histological definition of the disease. It can also have a surgical approach because a systematic review of all the structures of all the compartments of the pelvis can be accompanied and followed by the surgical removal of these lesions. It can also allow us to do a histological differential diagnosis between OMA or ovarian heteroplasm or cystic lesions of a certain nature. It should be performed within 3 months starting the hormonal therapy to avoid underdiagnosis. Now, talking about the instrumental diagnosis, we start with the TVUS, which is the transvaginal ultrasound, which is easily accessible, does not use, of course, ionizing radiation nor contrast agents. And it can allow us to differentiate OMAs, which are endometriomas, as we said earlier, from other ovarian lesions, especially teratomas, which are dermal tumors, cystic tumors, or hemorrhagic follicular cyst. For example, in this image on the right, we see 2 endometriomas, which are these lesions which we see noted in the image, which can have a modest and non-homogeneous appearance during TBUS, with a ground glass appearance especially, and during Doppler examination, they don't show any papillary structures with Doppler signal inside. In this image, we can also see a left hydrosalpinx, which is this dilated tortuous structure filled with anechogenic fluid, distinct from the adnexa. In this image, we see on the left side 2 endometriomas, confirming that there isn't any Doppler signal inside of them, and on the right side we see an intrinsic endophytic vesical lesion. We recognize the bladder because of its anechogenic content. Lastly, we talk about the magnetic resonance, which is far more reliable, of course, than the sonography in staging deep pelvic endometriosis, although it isn't used as a first-level tool, but as a second-level tool in surgical planning especially. It can allow us to do a high spatial resolution and multiplanar anatomical study of all the pelvis compartments. It can also differentiate all the types of lesions and the age and quantity of bleeding. In our protocol used here, we do an accurate patient preparation, which comprises of fasting at least 4 to 6 hours before the examination. The bladder must be moderately filled because an empty bladder can hide vesical lesions or adhesions, while a full bladder can obliterate the anatomical spaces. We must not conduct the study during the menstrual cycle, of course.
Yes, but can I ask you something related to the fact that it's difficult to have a moderately released bladder?
Yes, of course.
It's not. How do you know this?
Recently, we make the patient come with a full bladder. We empty the bladder.
Ah, okay, perfect. Okay.
And then we let them drink some water.
To overcome this kind of problem because you don't know how big is your bladder.
We make the patients empty their bladder and then give them water too. Okay. The vaginal specification with gel is not mandatory but recommended in case of suspicious vaginal lesion during a gynecological examination. The bowel preparation is done the day earlier with 1 liter of PEG administered orally, and the day of the examination avoiding rectal enema 2 to 3 hours before the exam. The rectal opacification is recommended in case of suspect rectosigmoid DIE, and the use of scopolamine and butyl bromide intravenously, which is a Buscopan, directly on the magnetic resonance table is recommended to reduce artifact from bowel movement. Talking about the scanner itself, we prefer using a scanner of 1.5 Tesla or 3 Tesla scanner. The patient position is feet first supine, but we can also use prone positions in case of claustrophobic patient, or in case of urographic study. And we use a phased array multi-channel torso surface coil, which means that this coil can cover a greater surface of the body while increasing the signal to noise ratio.
Sorry, it could be useful to use both supine and position in some examination.
Yes, of course, because the examination can also necessitate the use of gadolinium, which means that after 10 to 15 minutes we can do a urographic phase, positioning the patient in the proposition.
So the two main sequences for the diagnosis of the endometriosis are the two-weight single shot fast pinnacle and the two faster pinnacle not fast and the lava sequence that is a 2-1 weight 3D gradient fast. The T2 single shot in axle is acquired extending from the nail to the pubis, and are very fast sequences of about 20-25 seconds, but with a slice thickness of about 6 millimeters and low spatial resolution. And we use the axial single shot for identify the longitudinal axis of the uterus, so we can use it for a second localizer to acquire parallel and perpendicular to this longitudinal axis the sagittal, oblicoronal and axial sequence of T2 weight faster coifaxinaco. That are very long sequences of about 4 minutes with thin slice pixels of about 4 millimeters or lower, but with a slice spatial resolution and anatomical detail and an EX greater than 1. Being T2 sequence, this sequence have a long TR and a long TE and are not fat repressed for not mistake the hypointensity of the suppressed adipose tissue with the hypointensity of fibrotic tissue, and are the best sequence for the identification of endometriotic lesions, areas of fibrosis and pelvic adhesion. Meanwhile, the lava are the gold standard for the detection of the blood flows into the lesion and the endometriotic small lesion in the endometriotic small lesion, and are short sequences of about 20-25 seconds, prefold, 3D volumetric, and are acquired in sagittal, obliqual, coronal, and axial. Being T1 sequence, these have short hair and short E, and are fat suppressed this time for not confuse the hyperintensity of the adipose tissue with the hyperintensity of the bloody foci, and are acquired before and after intravenous injection of contrast agent. Meanwhile, the optional sequences are T2 star, DY, and Y. The T2 star are useful for the detection of the hemorrhagic content of ovarian lesion or other lesions, and highlights the magnetic susceptibility artifacts in the form of the signal void. Here we can see a case of an endometriotic implant in the anterior wall of the abdomen in a T2 coronal star. Meanwhile, the DY can be used for the identification of small endometriotic foci of superficial peritoneal implants, or for detect other abnormality of the sacral nerve roots or other inflammation. For example, here we can see a case in the image above of a T2 sequence with hyperintensity of the two salpings for the either salpings, and in the image below we can see the hyperintensity of the two salpings for the inflammation. Meanwhile, this Y detects the signal void from the blood degradation products in chronic endometric lesions. And we can see it, for example, in the endometriomas, such as dock-like signal void, or in the soup, such as linear signal void into the wall. Here we can see a case in a T1 sequence in the image above of an endovesical lesion with the intensity that represents the bloody foci, and the image below we can see the signal void of the blood. So we'll just speak about the principal lesions of the endometriosis. Now we'll see about the semiotics in MRI. For the superficial peritoneal implants, we have micronodular and microcystic appearance with the hyperintensity in FATSA T1 sequence, and that's have a moderate contrast enhancement after contrast agents. Here we can see a case of soup in Douglas pouch with indicated in this image with the yellow arrowheads. Meanwhile, the addition are visible in T2 sequence as an hyperintensity strands that teething the pelvic structure cause an abnormality of the normal anatomy pelvic. And here we can see a case of addition between the anterior wall of the rectum with the uterus, indicated by the white arrow, and a medial dislocation of the two ovaries. The solid endometrial lesions are visible in T2 white sequence as a solid hypointense lesions with irregular margins, with small hyperintense that represent dilated ectopic endometrial glands. And here we can see a case of a solid lesions that imprints and infiltrate the posterior walls of the bladder. Meanwhile, the hemorrhagic lesions are due to excavations of erythrocytes out of the glandular ducts into the stroma, and are visible in lava sequence as a hyperintensity. Here we can see a case of lesions in the retrocervical space that obliterate the posterior fornix and infiltrate also the anterior walls of the rectum. All these lesions have in common one indirect sign, the loculated anti-dialysis effusion, that if we see it in a T2 sequence, we can suspect a presence, for example, of an addition. And on the image on the right, we can see a case of a loculated effusion above anteriorly of the two ovaries. One of the most organs involved by endometriosis is the urinary tract, involved in 20% of cases, in which 85% is involved the bladder and 9% the ureters. In the bladder, the lesions are multifocal, in particular the trigon and the dome of the bladder, and we can have intrinsic involvement and extrinsic involvement. Intrinsic when the lesion infiltrates the internal layer of the muscular, and extrinsic when involved in the serous surface. Meanwhile, the ureters is involved in percent of cases, in particular the last tract, the last 3-4 centimeter of first from the bladder injection, and is bilateral in 10-20% of cases, in particular for the left ureters, for the movement of the liquid peritoneal in the abdomen that go up to the right, and this is the reason why we can have more frequently a site of right diaphragm that are respected to the left, and then go down on the left and stagnate on the left pelvic for the presence of the sigmoid tract, and here stay more in contact with the left ureters, and if cause an obstruction or a compression, we can have also hydroteresis. Here we can see a case of an intrinsic bladder involvement in a T2 sequence that we can see as an hypointensity in the left ureters injection, and on the right we can see a lava sequence with the bloody falls into the lesion. The ureter can be involved with direct and indirect. For the direct, when there is a focus that grow up directly on the ureters, meanwhile in indirect, when we have an involvement, an external involvement, and we can see in this image on the left, an indirect involvement of the left ureters, indicated by the white arrow, that surround the ureters, and with an axial oblique sequence we can see also the hydroureteronephrosis of the left ureters. The most common site of endometriosis are the ovaries in 20-40% of cases, and here we can have three types of lesions: micro-intraovarian endometriomas, small superficial implants, and the most frequent the endometriomas. Micro-intraovarian endometriomas outcomes from small cyclical hemorrhages into the ovary. Meanwhile, the superficial implants is small endometriomas, focus of endometriosis, that grow up on the cortex and don't go deeper than 5 millimeters into the parenchyma. Meanwhile, the endometriomas are cysts with an hemorrhagic content that link to a focus of endometriosis that grow up on the cortex of the ovaries, and then with the cyclical information it dig into the parenchyma, and the parenchyma became the walls of these lesions. Are multifocal and bilateral in 50% of cases, and we can have a pathognomonic sign of endometriomas that is the shedding sign, visible only in T2 sequence due to a shortened of T2 relaxation times for the blood products. And here we can see a case typical of the shedding sign on the left in the T2 sequence, not visible in T1 sequence. Another common sign of endometriomas is the kissing ovary sign that results from an addition between two endometriomas on the two ovary bilaterally, and is highly suggestive of endometriomas. Here we can see a case of two endometriomas with a loculated effusion anti-declive anteriorly to the two endometriomas. When we speak about this lesion, we must speak also about a differential diagnosis that we must do with the teratoma and the hemorrhagic corpus luteum. With teratoma, we can use easily the lava sequence that's at fat-sat, so we can suppress the fat into the amateur teratoma. Meanwhile, with the hemorrhagic corpus luteum, remember that this lesion don't have the shedding sign and also disappear in the next follow-up. Remember that the endometriosis have also another complication, an association with the two types of malignant lesions, the endometrioid adenocarcinoma that we can see on the left, and the clear cell carcinoma on the right. These two lesions occupying the uterine cavity, in particular that remember that the endometrioid adenocarcinoma tend to invade entirely the uterine cavity, and both have irregular walls, thickened septa, and a nodular enhancement. The other typical sites are the invasion of the vesicouterine pouch, and here we must repeat again the importance of the preparation of the patient, because here, if the bladder was empty, it is difficult to identify this type of lesion. And then the round ligaments normally are not visible in MRI. When we see it, we can have shortened, thickened or nodular appearance that represent an involvement of the endometriosis. Meanwhile, the salpinx, remember that the most common cause of hematosalpinx is the endometriosis, so if we see an hematosalpinx, we must suspect endometriosis. In particular, we can see hematosalpinx in T1 sequence for the presence of a tubular dilated structure, tortuous, hyperintense, that represent in T1, that have in T1 hyperintensity, that is the blood into the two salpinx. For the cervical lesion, this is another typical site of endometriosis, and here we can see it T2 sagittal sequence, and quello abbiamo scritto, vabbè, a T2 sagittal sequence that involved the anterior walls of the rectum and obliterate the posterior fornix of the vagina. And here we can see a typical case of rectovaginal lesions that infiltrate the left uterosacral lesion, and on the right we can suspect it also with the presence of bloody foci. When we have any involvement of the uterosacral ligaments, remember that the MRI is useful also for a surgical planning, because after bilateral resection of uterosacral ligaments are often there is also urinary disorders. And when we have this type of involvement, remember that the uterosacral ligaments are often associated with an infiltration of the rectal anterior walls. So in the T1 sequence, we can see this infiltration. For the vaginal lesions, remember that the most affected locations are the proximal third and the posterior fornix, and here we must speak again about the preparation of the patients. If the clinical help us say that with a gynecological exam he notes nodularity of the posterior fornix, we must use an echographic gel for distend the vagina, and that help us to the identification of the lesion. Here we can see the difference between T2 sagittal with gel and without gel. See that the echographic gel distends the vagina, and we can identify the lesion more easily.
Sorry, you do both examination with empty and fully vagina?
Yes, with gel and without gel. and the white arrow indicates the obliteration of the posterior fornix, that it's more easily visible.
Why don't you do only the fully image with the fully vagina?
With the full,
With
You
Pietro
do the
V.
examination with the empty and filled. Why don't you do the only filled examination?
because it's not visible. It's
Why?
not visible. With the gel, it's more easily visible. With the
Yes, but I say, if you see this kind of lesion with the filled vagina, why don't you do only filled vagina examination?
no, we do this for have a conflict between the
Comparison
two
with-
cases.
Okay.
Here we have the involvement of the colon. The most affected tract is the rectum sigmoid, followed by appendix, terminal ileum, and descending colon. Remember that the endometriosis lesion starts from the surface surface and tend to infiltrate the internal layers. And when arrived to the mucosa, we can have a typical sign that is a mushroom cap sign, that is represented an intraluminal endophytic glow of the mucosa. Visible here with the black arrowhead, and visible also in this image in a sagittal tissue image from the black arrowhead. Remember that when the endometriosis infiltrates the internal layers, the most common complications are adhesion, strictures, and bowel obstruction. And the best imaging modality for determining the involvement of the internal layers is represented by the TIPUS. Remember that we must do a differential diagnosis with a colorectal carcinoma. Remember that the colorectal carcinoma tend to infiltrate the external layers with an infiltration of the mesorectal adipose tissue and the lymph node. And the differential diagnosis we can do with contrast agent for the intense contrast enhancement of this malignant lesion. At the end, we can see two atypical sites of endometriosis, the diaphragm lesions that we can have it with a single cluster or nodular plaque lesions, and from the nerve lesions in another atypical site. Remember that most involved nerve are the sacral plexus and the sciatic nerve on the sciatic notch. And these lesions, we can see it's equal-intense in T1 and T2 sequence. And then after contrast, we can see the hyperintensity of this type of lesion. So for conclusion, the pelvic MRI is a non-invasive modality with high spatial resolutions. Without the use of ionizing radiation or ionizing constant agent, and is useful for the identification and the characterization of endometriotic lesions, and have a key role in the surgical planning. But the gold standard for the management of endometriosis are a tailored approach based on the desire of the patients and the severity of the clinical frameworks. Thanks for your attention.
I would like to congratulate, because this is the first step, English step of this research. So it was a very tough subject, because it's not easy. For one L1 resident, it's not easy to follow, even for me, because I'm not so involved in this kind of subject. I would like to have some comment also from Professor Foti, because he's a very high-level expert in this subject. So should be Pietro for this. Of course, as you realize, the most difficult point of the situation is to understand the questions and, of course, to reply. Because, of course, it's easier to prepare a speech like this. It's more difficult to understand the questions. For example, from an Asian guy, the Asian guy from Korea, from China, from Japan, they speak very closely English. Very close English, so it's not easy for this. But of course, as much you are aware, as much you are trained in this, as better you are able to understand and to reply. It's something that is training, and this is the reason why we start with this kind of English session. So, Pietro, please, will you ask you something, or do you have some comments on this?
So I'd like to thank Professor Basile for the invitation, and let's congratulate with Stefano and Roberto for the beautiful presentation. I'd like to point out some point of this presentation. First of all, the importance of intestinal preparation for the good quality of the MR examination is mandatory to perform an EMA, rectal EMA, in order to eliminate all the residual stool, rectal stool, and so make the endometriotic foci more hyper-intense on T1-related sequences. And this is mandatory for the good quality of MR examination.
Okay. That's all,
Thank you,
Pietro.
Pietro.
Thank you,
Okay.
Steph.
I would like to congratulate again our colleagues, and I hope that in the future the level of our English will improve, the accent and so on. But the first point is to be understood, not to have a Cambridge accent. We cannot have Cambridge accent, absolutely not. We had to go there for 3 years, and once coming back, perhaps we will have a Cambridge accent. So don't focus your attention on accent. Focus your attention on fluency, more than accent, more than details. Okay? Perfect. Congratulations again.